Welcome back to the deep dive. Today, we are undertaking a pretty intense structural expedition.
We really are.
We're going into one of the most mechanically and I guess functionally complex regions of the entire body, the pelvis and the perineum.
This is truly foundational material. I mean, if you can map this geography in your mind, you unlock the function of the urinary, reproductive, and digestive systems all at once.
Wow.
So our mission today, really, is to create a crystal clear mental map. We'll start with the unyielding bony frame, move through the functional floor, and then, dissect the layered zones that house all the neurovascular lifelines.
And for this, our sources are the best kind detailed anatomical dissection guides.
The blueprints.
Exactly. They give us that systematic step-by-step tour. They really emphasize the crucial landmarks and pinpoint exactly where the critical arteries and nerves are running. It's like the ultimate architectural guide to this very busy intersection.
It's the difference between just seeing a map and knowing exactly where the utility tunnels are.
Right.
That precision is what we're focusing on.
Okay, let's unpack this. We have to start with the foundational structure, right? The bony fortress that supports everything. The pelvis itself.
Right. So when we look at the pelvis, the sources immediately force us to divide it, conceptually, into two main regions. Think of it like a huge basin.
Okay.
Superiorly, you have this wide, flared area. That's called the greater pelvis, or sometimes the false pelvis.
The false pelvis, why false?
Well, it's primarily defined by the broad wings and the iliac crests, and it mostly just acts as a support for the abdominal contents before they descend. It's not the main container.
So the false pelvis is basically the waiting room for everything that's destined for the true core.
Exactly. The real action happens in the lesser pelvis, the true pelvis.
Okay.
This is the deep, crucial inferior basin. It's bounded by thick bone, and it's the space that fully contains the internal organs we mentioned, the bladder, rectum, reproductive organs. Its floor is that muscular sheet, the pelvic diaphragm.
So if the lesser pelvis is the room, we need to define the entrance and the exit.
That's right.
The entry point would be the pelvic inlet, which is often called the pelvic brim. And this isn't just a simple circle, is it? It's a very precisely measured boundary.
It's beautifully contoured, and the structures defining it, they collectively form the linea terminalis. We start right at the back with the promontory of the sacrum.
Okay.
Then we sweep laterally past the sacroiliac joint along that sharp arcuate line on the inside of the ilium, connecting to the pecten pubis, and finally meeting the pubic and symphysis at the front.
And that complete ring defines the entire upper limit of the true pelvis.
You got it.
So moving to the bottom, we have the pelvic outlet. This is where we transition from that bony cage to the soft tissue floor, the perineum.
Yes.
And what's fascinating here is how ligaments come in and reinforce the bony margins to create these functional passageways.
That's the key piece of engineering. Yeah. The outlet is bounded by bone pubic symphysis in front, coccyx back, but its lateral stability relies so heavily on two specific ligaments.
What's that?
You've got the thick, robust sacrotuberous ligament, and then the more fan-shaped sacrospinous ligament.
And these two ligaments are so critical because they partition a couple of huge spaces into, useful, narrower conduits.
That's right. The sacrospinous ligament attaches to a vital landmark, the ischial spine. And here's the first major physical marker you really need to lock into your mental map.
Okay.
The sources repeatedly stress this. The ischial spine sits approximately 1.5 inches above the ischial tuberosity.
1.5 inches.
Yep. And these structures, the bone and the ligaments, they define the greater sciatic foramen, the exit for the body's largest nerve, and the lesser sciatic foramen.
Okay, that is a brilliant piece of practical knowledge right there. So we've mapped the strong bony foundation and its major exits. Now we transition out of that bowl and look at the floor suspended underneath it.
Yes. Let's move to the perineum.
The diamond-shaped outlet.
The perineum is, well, it's literally the region beneath the pelvic diaphragm, right between the thighs. It's the entire inferior boundary of the torso.
And if you look up at it from below, it's not a square or a rectangle. It's a perfect diamond.
A perfect diamond.
So what are the 4 points of that diamond?
We can define them by just palpating the bony structures. Anteriorly, you have the pubic symphysis.
Okay.
Posteriorly, the tip of the coccyx.
Okay.
And the two lateral points, those are the prominent ischial tuberosities.
And this diamond shape is just anatomically brilliant because it's not one single space. It's organized by function.
It is.
And the key organizing principle is drawing an imaginary line, a transverse line, between those two ischial tuberosities.
That line is the watershed. It splits the diamond into two very distinct, very functional triangles. Anteriorly, we have the urogenital triangle,
Okay, urogenital.
which manages the external genitalia and the exits for the urinary and reproductive tracts. Posteriorly, we find the anal triangle, which is strictly concerned with the gastrointestinal exit.
And since the posterior region is simpler, let's start there.
Good idea.
Deep dive into the anal triangle, right in the center. What are the key structures that define that exit function?
Immediately, right in the middle of that triangle, you obviously find the anus.
Right.
And that's ringed by the strong, voluntary external anal sphincter, what your guide calls the M sphincter ani externus. And then stretching from that sphincter back to the coccyx is a supporting structure, the anacoccygeal ligament.
But the posterior triangle isn't just the exit hole. It's surrounded by this massive, fat-filled space, right? The ischiorectal fossa on both sides.
Also called the ischioanal fossa.
So if it's just packed with fat, why do our sources spend so much time detailing its complex boundaries? Is it vulnerable to something?
That's a great question, and it speaks directly to its clinical significance. This wedge-shaped space is, you're right, largely filled with ischioanal fat.
Which allows for expansion.
Exactly. Distension of the anal canal during defecation.
Yeah.
But because it's full of this loose connective tissue, and it's so close to potentially contaminated spaces, it is a prime location for abscesses, for serious deep infections.
Ah, so you have to know the boundaries to understand how an infection would spread.
That's it. Or where a surgeon needs to drain it.
Right.
Understanding the boundaries defines the limits of infection. The base is just the skin. Medially, it's bounded by the levator ani muscle and the external sphincter. Laterally, you're right up against the bony wall covered by the obturator internus muscle and its fascia.
And it has limits above and below, too.
It does. The superior limit is at the origin of the levator ani, and it's contained front and back by the urogenital diaphragm and the sacrotuberous ligament.
Okay, now, this is where we find, I think, the most critical piece of the entire region. Running horizontally along the lateral wall of that fossa, along the obturator fascia, is the absolute lifeline for the entire perineum. We're talking about the pudendal canal.
Alcock's canal. Yes, this canal is the main utility tunnel for the floor.
And this is where that landmark we stressed earlier comes back, right? The 1.5 inches.
Comes right back into play. That precise location, 1.5 inches above the ischial tuberosity, is where you access this canal to perform a pudendal nerve block.
Which is used for?
Pain management during childbirth or for chronic pelvic pain conditions. Knowing that exact geography transforms from, an academic fact into practical medicine. It's critical.
That really brings the structure to life. So inside this critical utility tunnel, what are the primary contents? It's not just one wire, it's the whole bundle.
It's the whole bundle. It contains the entire internal pudendal vessel, the artery and the veins, and the principal nerve, the pudendal nerve itself.
Yeah.
And crucially, that nerve starts branching almost immediately.
Right away.
Almost right away. It gives off the inferior rectal nerve, the perineal nerve, and then finally its terminal sensory branch, the dorsal nerve of the penis or clitoris.
So that one canal is handling the vascular supply and the sensory and motor control for both the anterior and posterior utility zones.
Incredible efficiency.
It truly is. Fantastic. Okay, we've mapped the posterior half. Now let's move anteriorly across that dividing line into the much more layered and compartmentalized urogenital triangle.
Right, and the urogenital triangle is more complex because we have to think vertically.
Ah, in layers.
It's not just a flat space. It's stacked into two distinct areas or pouches, and they're separated by this tough sheet of connective tissue called the perineal membrane.
And immediately superficial to everything, closest to the skin, we find the outer wall of that superficial space, which is calcis fascia.
Yes, the deep membranous layer of the superficial fascia. Its boundaries are a major point of emphasis in the sources.
Why are the boundaries so important?
Because they define how fluid and infection spread. Calcis fascia is continuous anteriorly with the dartos fascia of the genitalia, but, and this is key laterally, it attaches rigidly to the pubic arch and the fascia lata of the thigh.
Wait, rigidly? So if it attaches rigidly to the pubic arch, what does that mean clinically?
It means that if there's trauma or fluid accumulations, a serious infection or a rupture in the space just deep to this fascia, that fluid cannot track down into the thigh. It's completely contained, which leads to a very specific, sometimes dramatic pattern of swelling that's contained only within the perineum, scrotum, or penis. That rigid attachment dictates the whole spread.
That makes perfect sense. So with callus fascia as the superficial boundary and the perineal membrane as the deep boundary, the space between them is the superficial perineal pouch.
Precisely. And superior to that perineal membrane, separated from the true pelvic cavity by the deep muscles of the urogenital diaphragm, lies the deep perineal space pouch.
Okay, let's focus on the superficial perineal pouch. This is like the dedicated workshop for the external genitalia.
That's a good way to put it.
It contains the all-important erectile bodies. And we have to remember they change their names as they transition from their attachment points to their main shafts, right?
Yes, exactly. The posterior attached parts are known as the corros of the penis, or clitoris, and these become the corpus cavernosum.
Got it.
And the central structure is the bulb of the penis, or vestibule, which then becomes the corpus spongiosum.
So since this pouch is the destination for so much function, it must be loaded with the final terminal branches of that pudendal system we tracked earlier.
It is absolutely packed.
Let's group the nervous and vascular supply here. How does that work?
Okay, so if we follow the main nerve, the pudendal nerve, its branches supply 3 functional areas right here in this pouch. First, you have the perineal nerve, which gives motor and sensory supply, including the posterior scrotal or labial nerves.
Okay, 1.
Second, the motor supply to the erectile tissues themselves, the nerve to the bulb of the penis, or vestibule, and then finally, the primary sensory branch that runs right along the top of the external organ, the dorsal nerve of the penis or clitoris.
And I'm guessing the vascular system, driven by the internal pudendal artery, just mirrors this delivery perfectly.
It mirrors it absolutely perfectly. The artery sends corresponding branches, the posterior scrotolabial artery to the skin, the artery of the bulb to the central tissue.
Corpus spongiosum.
Yes. Then the deep artery of the penis clitoris, which runs right through the center of the corpora cavernosa, and finally the dorsal artery of the penis clitoris, supplying the skin and fascia. This whole highly specialized vascular arrangement is what facilitates the function of the external genitalia.
What a dense and incredibly organized space. We started with the solid foundation of the lesser pelvis, defined the exit through that diamond-shaped perineum,
Dissected the simpler anal triangle with its critical fat-filled fossa, and located that indispensable pudendal utility tunnel.
and then finally we saw the complexity of the anterior urogenital triangle, appreciating how the layering callus fascia, the perineal membrane, creates these sealed pouches.
Pouches containing the erectile bodies and their specialized neurovascular supply.
So what does this whole journey tell us? I mean, the sheer anatomical precision required.
Right.
The exact location of the ischial spine being 1.5 inches above the tuberosity. The rigid attachments of callus fascia. It all shows how vital structural clarity is for clinical practice. This isn't just a collection of bones and tubes.
Not at all. It's an integrated system of engineering solutions.
Yeah.
And if we connect this to the bigger picture, it really raises an important question. Considering this tight structural convergence, where the urinary, reproductive, and digestive tracts share this tiny final exit corridor,
Right.
just think about how the interconnected network of the pudendal nerve manages to perfectly coordinate the voluntary and involuntary actions like continence, voiding, arousal of 3 distinct physiological systems.
All at the same time.
All at the same time, all within that small, highly structured space. It's a remarkable feat of control.
An incredible system to ponder. Thank you for joining us for this deep dive into the anatomy of the pelvis and perineum.
I hope this structural map serves you well.
We'll see you next time.